Okay, so here's British Columbia, and as John says, it's a big province. So we've got the north, which is, as he said, about the size of France, or Germany. The interior health region itself is about the size of Switzerland. Vancouver Island is about the size of England, so it's a big province. We've got some stations all the way around it. So up in Prince Rupert, we have a rotor, of course, the S-76, that's staffed by PCPs. We have a new air base up in Fort St. John that's a fixed wing staffed by PCPs. We have our Prince George Critical Care Program, that's a fixed wing. Then down in Kamloops, we have a CCP rotor base, which is probably our busiest trauma base in the province as far as our auto launch and first response with the aircraft go. You're getting too fast for me, or is it just happening? Anyway, Kelowna has 2 fixed wings, which are CCP mainly, but sometimes one of the planes will be a CCP ACP doing some lower acuity. We have a ground-based CCP crew in Nanaimo servicing the island. That occasionally we'll have helicopters brought over to it if necessary, but most of the time we're doing ground response. Then we have our largest base is in Vancouver, where we have 3 fixed wing and 2 rotor, and our main depot with most of our critical care paramedics. And there's another clip. Yeah. So we also have based using the same resources in Vancouver is our critical care infant transport team. So that's our resources around the province.
I think one of the important things to delineate here is when you look at all the bases, it looks like we have a lot of resources, and we have some resources that are spread throughout the province to sort of accommodate a quicker response time, but our only 24-hour base is the one in Vancouver. So both our critical care and infant transport teams are the only 24-hour base. All the other bases are day shift only.
Oh, and the part of the Vancouver base will be sent out to the Fraser Valley to do ground transports. So one of the challenges we've had in the last couple of years is we've gone from a provincially wide managed one to a regional management of our bases. This provided more local oversight, but it's sort of caused us a little bit more of a work as far as overall direction of the program is a little less coordinated. So that means when Rob and I are traveling around, there's a little bit more for us to do. But from a medical point of view, we're still providing, through Rob and myself, the same medical oversight and education that we were before. The challenge will be, as we move forward, trying to implement any new care models or processes amongst all the bases as we move forward. One of the big things that's happened for us in the last year is we've been able to get night vision for our rotor resources in Vancouver, Prince Rupert, and I believe, Randy, they're now in Kamloops?
A couple of weeks away.
A couple of weeks away. This will be a big change for us to be able to respond to some of our calls, because due to our mountain ranges, we're often quite limited as to the tolerances in which we can fly in, so this should open it up a bit more. So I'm sure there's people in the room will be watching the responses to see what the changes will be. One of the other big changes is our PCP bases. Historically, our AirVac program ignored PCPs. So we had that rotor resource up in Prince Rupert since 2003, which really had no medical oversight over it. And so in the last couple of years, Rob and myself have taken on the responsibility to try and get those paramedics some oversight, some support, and some medical education. So they really are now part of our AirVac program, the way we look at in case of their oversight. Anything that they do in an aircraft is our responsibility. To do that, well, there also is a new PCP wing, fixed wing started in Fort St. John a year and a half ago. Is that right? Yeah, about a year and a half ago. And again, they have no local medical oversight for anything they do in the plane. So we've taken them over. So our air program hasn't really expanded, but the medical oversight's expanded. So they really needed some skills enhancement, and they really need some maintenance of their competency.
Oops, it's gonna stay.
And so to do that, we developed a flight course for the PCPs, and we really want to thank Orange for their help in this. They had a sort of an online course that we would start with, and we took a lot of their curriculum. So Again, these meetings are really important. The things I've learned over the years, just by coming to these meetings and talking to the rest of you, has been very, very helpful.
So one of the things that we've tried to accomplish over the last little while in terms of bringing our PCP resources into the AirVac world and formalizing some of these processes is to give them some basic training so that they know how to apply their level of medicine and their level of practice in that air medical environment. As we know, it's not just another ambulance. So we've spent some time over the last while, and we've stolen from some of our colleagues throughout the provinces, and we've created a flight certification designation that we're trying to get some momentum on and roll out throughout the province. And that's really looking at PCP practice, ACP practice, and how you apply that level of medicine in the air medical environment. This includes things like Dunker training, safety training, rescue training, those types of things. And then this allowed us actually to bring these folks into our maintenance of competency model, where we didn't really involve them before. Their involvement historically was mostly ad hoc. We would go once in a while when we had something we needed or felt like we needed to chat with them about. And this formalization of this process has allowed us to move into a formal maintenance of competency approach. To date, we've run the program 4 times, and we have roughly 40 flight certified PCPs and ACPs throughout the province.
One of the things that sort of was serendipitously was happening around this time is that BC Ambulance Service was looking at ketamine for PCP use. And so we've introduced intranasal ketamine in the analgesic dosage range. And we introduced that first into our PCPs up in Prince Rupert back in November. And then in January, we went up and introduced it to the flight PCPs on the aircraft there. This is based upon a study that we did here within British Columbia. I was hoping Sandra would be here today, but she's on maternity leave. But this is going to be published sometime in the next few months. It's about intranasal ketamine. Showing that it does have analgesic effect and is beneficial to the patients.
So one of the
Go ahead. Yeah.
Sure, I'll go. This is where we cut each other off. So one of the challenges that we have, obviously rolling a controlled substance out into the communities, is the control and the tracking and the legalities around having these controlled substances. So it was a bit of a challenge for us when we originally kind of were pioneering the idea of moving this forward. We were really concerned about how do we maintain everything we need to maintain in form of our CTS tracking. So we spent a thorough amount of time, and I think we actually put the fear of God into some of these people, quite honestly, about what might happen with the RCMP knocking on the door if their documentation is incomplete. Some of it may have been embellished just slightly, but that said, we were able to put biometric safes into these places. We were able to train the primary care paramedics and the advanced care paramedics on the appropriate and required CTS tracking documentation. To date, we have had 0 issues so far. In fact, they're probably better than a lot of our critical care folks. Adam, sorry to say, but they do a really, really nice job of this.
So the thing about intranasal ketamine is it's the particle size is the thing. They come out with these new sprays that are micron in size that cross straight up into the brain through the olfactory nerve as well as through the mucous membrane. So remarkable effect. We can skip to the next one. So this is our how we use it with our aircraft. We use a pain scale greater than 5 that can give 0.75 milligrams per kilogram. And after 20 minutes, they may repeat it 0.5 milligrams. Our Prince Rupert experience is that we've had 42 cases and 3 adverse effects, which were pretty minor: dry mouth, spaced out, and increased anxiety. The pain pre-medication was on the pain scale was 8.1. Pain 10 to 15 minutes post first dose dropped to 4, and that was on an N of 29. Pain post second dose, N of 5. So pretty effective. It gave them a tool that they didn't really have before.
One of the other things that we've been noticing, just as comments, we've been gathering all the comments for all the cases that have been basically been given pain medication by the PCPs. And some of the comments are really interesting, even if there's not a drastic reduction in the overall pain. The comments are that the patients seem to be more relaxed, they settle in, they go to sleep. When they poke them and ask them what their pain scale is, it seems to be back to where it was, but as soon as they leave them alone, the overarching comments are that they just seem much more relaxed, they settle in, and the transport goes without event.
Blood. So it's great. In the last couple of months, we've introduced blood to pre-hospital blood. We've been able to access it for about 5 years, but we would have to go into Vancouver General to get it. And obviously, this was lots of delays, so it had low usage and really wasn't effective for our auto launch. So we started storing the blood at Vancouver, our station there. Really want to thank STARS Manitoba and Zoe for presenting this 2 years ago and then giving us an update last year. It was really helpful, and I can hear about the cooler technology. So that really allowed us to move ahead. But one of the big things, of course, is just personnel. We had a new transfusion services head at Vancouver General that just suddenly opened the door for us. So it was a bunch of things coming together at the right time. And so hopefully, if this rolls out, we'll be able to get it to our other all-launch helicopter up in Kamloops later this year.
So one of the other initiatives that we've been utilizing over the last couple of years is EEG monitoring for patients who are undergoing sedation, primarily for mechanical ventilation, but also for the purposes of procedural sedation for things like facilitating physical restraints. We obtained the device back in 2017. We were literally at a critical care conference. The critical care director at the time, we saw a little demonstration on this technology. He whipped out his credit card and said, we need to buy one of these things and try it out. And so we've been using it ever since. We've trained all the CCPs in this procedure, and anybody that's being mechanically ventilated, anybody that has ongoing sedation going, we're using this technology to be a bit more sophisticated, to be assured when we've reached an adequate level of sedation, either whether they're paralyzed or whether they're just heavily sedated to whatever our specific RAS goals are. One of the reasons we do this is a couple of things we've learned over the last few years around Icu Delirium, being more specific, trying not to cause harm. As you all appreciate, the air medical environment is different than being in a nice quiet hospital, quiet ICU, emergency department. We end up having to apply a lot more sedatives during that transport environment to maintain the same RAS goals. So we want to use the minimum amount of drug that we need to accomplish those goals, so when they get to the receiving center, they're not snowed for 4 or 5 hours and we can't do a proper assessment there. So we're using that technology to help us be a little more sophisticated in our anesthesia planning, specifically for phase 2 and ongoing maintenance of anesthesia. It's really a process of just frontal cortex leads that are applied. We're teaching the paramedics how to interpret gross EEG waveforms, as well as looking at muscle artifact and a host of things to be able to assess what an appropriate level of sedation would be during the transport. It's really boils down to some very simple principles as we kind of go through. Anybody with sort of high beta waves, somebody who's awake, anybody with decreased activity, somebody who's getting more into that sedate range. So we can kind of guide how we really induce this anesthesia by what type of EEG waveforms we're seeing and what to try and avoid in terms of oversedation. Talk about this, Steve?
So yeah, one of the actually other effects or other uses that we found is with our psychiatric patients. We've been able to put these monitors on and again dial in the exact amount of sedation we want for these patients. So we've gone away from completely having to intubate some of our most violent patients to the point that we can now start an IV and give them IV of propofol or ketamine. And actually there was a case on the weekend that one of the paramedics was involved in. And how did it work, Adam?
Very well.
So it's allowed us to be able to fine-tune how we sedate our psychiatric patients.
There's obviously a little bit of concern from our anesthesia group and our medical oversight when we're running a maintenance infusion of propofol or ketofol on a patient who doesn't have a secured airway. So one of the things that we are absolutely insistent on is that the patients are one-on-one monitored, eyes on the patient, cardiac monitoring end-tidal CO2, and we're using the EEG and all of our physical and clinical assessment skills to make sure that we don't have misadventure. during that process.
Our psychiatric transfer process has gone on hold in 2017 due to a lack of backup from the psychiatrists that would do the assessments. However, we've been able to continue using the bar stool in some situations. We are mandated to transport these patients, so we're working forward, and we have and that's what sort of pushed us into change our approach with the propofol drips. Also, the Pinel restraints, I don't know if you have these in your organizations, but a huge change and better restraints than the old leather ones. Much more comfortable, much more secure.
So one of the things that we've moved to, and that the Pinels really have allowed us to adopt, is our old philosophy was really around chemical restraint. So we would give patients high doses of sedatives to render them chemically restrained. Once we introduced the Pinel restraints into our practice, and once we realized that from Transport Canada perspective that we were actually able to do this, we switched our philosophy really from a chemical restraint process to a physical restraint process, and now we use a sedative purely to facilitate physical restraint. So the amount of the deep sedation that's being required for violent psychiatric patients has been drastically reduced. We used to have to go to the point of actually having to secure an airway from time to time in patients that were deeply sedated. Going to a philosophy of physical restraint and and using the chemicals just to facilitate the physical restraint has really helped us out with that.
And it's really improved the care. So we can turn off the medications just before we get there. They don't have to go to an ICU or a post-op to get extubated. They can go straight to the site receiving. They're not overly sedated when they get there. And prior to this, we would get reports from these site receiving centers that these people would fall and break their hips if they were elderly. So all the way around. I don't know about you guys, but we have a huge challenge right now. We've got the pig going through the python, or maybe in this picture it's a cat going through the snake, I don't know. But our baby boomers are all retiring. So it's really straining our learning department at this point. We have yearly ongoing classes of critical care paramedics where we train them in-house. It's put significant strain on our system because we haven't used our CCPs as educators and mentors. It's also hard as more people we take into our program. It's becoming more and more difficult to find suitable candidates as we move on year after year. And it's straining our pressure to maintain our maintenance of competencies at the same time training new students.
Yeah, we've moved really historically, probably 5 years ago or even 4 years ago, where we would do cohorts back to back. So the program was 2 years in duration previously, and every 2 years we would have an intake. To try and get ahead of the retirement so that we actually have a program and staff to run the program, we've been taking annual intakes in. So that's put an extreme amount of pressure on the learning department, on operations, because we're bringing people out of operations. We're also using operations people to help us instruct. So it's been a big resource in terms of human resources to maintain the staffing.
And it's most extreme with our critical care ITT teams. We're at this point unable to fill some shifts. And so what's happened is that it's put increased demands on our adult CCPs. So over the last 2 years, Rob and I have put a real emphasis on going through the CCP bases and doing a lot of pediatric education so they can start to facilitate some of the transfers ITT can't get to.
A couple of the other initiatives that we've been going with over the last couple of years, and thanks to our colleagues in Nova Scotia that gave us this idea. Steve and I were out there and they were talking about this prone transport that they were doing, which got us intrigued. So we started a prone process as well. And basically what we did is we went out through all the CCP bases. We established some criteria for patients who should be consideration for prone mechanical ventilation. That's patients who are in the ARDS population, patients who have been optimized on a mechanical ventilator, and patients who have a PF ratio of still 150. So once we get to a PF ratio of 150 after they've been optimized, we now start thinking about whether this patient will benefit from prone mechanical ventilation. And we've been doing a few of these things. Really, a lot of this stuff is patients who are flirting with ECMO out in the communities and that need to come back. So the plan is, we're putting them in a very austere environment, so we want to optimize that as much as possible and not do harm during the transport so that we can transport them safely. We've been doing a number of these over the last while. I think we're up to about a dozen air transports that we've transported prone. This is just part of our training package. We went through and trained them very systematically on how to actually do the proning of these patients. We use mannequins, and then there's just an example of one that actually Adam did just the other day.
Cadaver Lab, I want to again thank George in Nova Scotia. It was a great exposure last year at the CAMT conference there. We ran our first Cadaver Lab just 2 weeks ago. So thank you, George. We're teaching with our second year class of CCPs, and hopefully we can continue to do this. It was extremely well received, and again, thanks very much. And, I looked at this slide, which we took a couple of weeks ago, and it took me about 30 seconds to figure out who the bald guy was. Yeah. Okay. Hopefully in the future, we've got a few things cooking. Joe here has started an initiative to try and get some regulation changes. We hope to be able to start doing CCP finger thoracotomies, and our critical care paramedics hopefully will be able to start putting in chest tubes. But that's in the future. Thank you very much.